All right. Okay, good morning, everyone. Could someone in the back tell me, is this on? Give me a thumbs up. Okay. Ish. Okay, I'll talk louder. How's that? All right. So today we're going to talk about the medchem of antiarrhythmic drugs. I'm going to try to keep it simple a little bit by focusing on one drug in each of these classes that Dr. Castleberry had talked to you about. I'll talk about one in the sodium channel blocking class, quinidine. I'll talk about a few more actually in the beta blocking class. Those in the class 3, amiodarone, and then some improvements that are being made on that. And the fourth class we covered already with the calcium channel blockers. So I'll just refer you to a previous lecture. Okay, so first one, quinidine. I could zoom in a little more. So its main target here is cardiac sodium ion channels. It also can target potassium channels. It's shown use-dependent block, so its binding site is revealed when the channel goes through these conformational changes. And so it'll only bind to this open form of the channel. So use-dependent. And that's sort of shown here. If there's a binding site that's occluded, once it's open, the quinidine can come in and bind. And by inhibiting or antagonizing these sodium ion channels, and also by inhibiting the potassium ion channels, you can cause this frequency-dependent decrease in this tissue responsiveness and slow the arrhythmias. Now, what do we know about the target, this sodium ion channel? Here it's also shown as the potassium ion channel, but the sodium ion channel similar. Similar. I better zoom back out. There we go. Now you saw this type of channel before. It's a transmembrane spanning protein. It transverses the membrane 6 times, but in between the 5th and 6th, it kind of dips in the membrane and out. And each of these packed together in a bundle, and that sort of loop, that P-loop, focuses on the inside of the pore. And 4 of these come together to make a channel for your, here it's shown potassium, but I like to think of it as the sodium ion channels too. Similar structure. Now, a bunch of mutants were made in the lab in this channel to see which one could block out quinidine binding, and that way they could find where on the protein this binding site is. And what they found is that they sort of map on the same side of this transmembrane domain 6 as the P-loop, so they think it binds sort of close to the inside of this channel, suggesting also, similar. They don't have high resolution, but the idea is that it's only accessible when this channel is open. Okay, that's the target. How about what quinidine looks like? The structure is shown here in the middle, and I show different ionization states on either side. The crude isolate was found from this tree bark in 1600s, and it was first isolated by this guy Walter Frey. Not a lot of Walters, so I have to do a little shout out. There he is. You've probably heard of quinine, which is an antimalarial, and is in some drinks, and it's actually a diastereomer of this. So 2 of these sites. Some of these stereochemistries are the same, but 2 of these are different, so they don't bind to the same receptor. I tried to capture this in a little a cartoon, the mosquitoes looking in the mirror, So quinine and quinidine, those 2 sites are kind of mirror images of each other, but one is antiarrhythmic and the other one is antimalarial. It's not quite a true picture because some of the chiral sites are the same, but anyway. Both of these are fluorescent molecules. I'm not this cool, but apparently if you go to cool bars, sometimes drinks are fluorescent, and that's the quinine in them. Not quinidine, but quinine. All right, so what does this look like? So we have this quinone ring, sort of which gives it its the Q in its name. You've got two nitrogens on here, and both of these can undergo ionizations. This one gives us a proton early, around 4, so at very acidic pHs it can protonate, but most of the time it's in this neutral form. And then if you go to this other one, can hold on to its proton better, and when you get to basic pHs above 10, you predominantly lose this form. And these two rings, the quinone ring and the quinucleidine ring, are just linked by this simple hydroxymethylene linker. All right. It's pretty soluble, as you might imagine, with those positive charges when you make the salts of these. Very high oral absorption. But a lot of it turns out to be plasma brown. Almost 85% of this gets bound to plasma protein. And you know, sometimes that causes a problem with drug-drug interactions because if it's bound to serum albumin and another drug comes in and binds, it can kick that off and change the serum concentrations. You can get renal excretion of the unchanged drug, about 50%, up to 50%, and you get metabolism in the liver at two different places. This methyl ether can get O-demethylated to make this phenol, and then you can get hydroxylation out here on this this carbon in the quinucleidine ring by cytochrome P450 3A4. Now, I alluded to some drug interactions, and although it gets metabolized by that cytochrome P450, it also strongly inhibits a different one, the CYP2D6. And that's a major pathway for oxidation of other drugs, and so inhibition of this can lead to adverse drug-drug interactions. And there's a particular one because digoxin is often used in similar clinical conditions. So it actually has another drug-drug interaction with digoxin that's a little bit different. We'll cover medchem of digoxin a little bit later, a couple lectures later. But if you give quinidine to these patients, you can get a fairly large increase in the plasma levels of digoxin. That's because when we get rid of these, they go through this ATP-dependent efflux pump called P-glycoprotein. And they both want to use that efflux pump to sort of get out of your system. But quinidine is a better competitor than the other, so it prevents digoxin from getting eliminated by that efflux pump here in the kidney. And you don't get as much elimination of digoxin by the urine, so you get higher plasma levels of digoxin because it more effectively competes for this. So I guess in both of these cases, you know, quinidine isn't totally specific for binding to the protein that we intend it to, that sodium ion cardiac channel. And by binding to these other proteins, it can lead to these adverse effects, either to this cytochrome to inhibit it, or as a substrate to this efflux pump. Okay. All right, so that's class 1. How about class 2? Beta adrenergic receptor agonists. These are called beta blockers. But if we want to unpack what do you mean by blocker, it just means they're acting as antagonists at that beta adrenergic receptor. Okay, so what normally happens at that receptor? First, let's look at agonists, so compounds that increase the activity of that downstream of that receptor. So these aren't the therapeutics in this class. We're going to look at antagonists. But normally when agonists bind, This beta adrenergic receptor is a G protein coupled receptor. It can bind through this G protein signaling, can activate adenylyl cyclase to raise levels of CAMP. This acts as a second messenger, which results downstream. You phosphorylate these L-type calcium ion channels and allow increased calcium ion to come into the cell. And we saw before in the calcium channel blocker lecture that this calcium influx impacts heart muscle contraction. It can actually increase that heart muscle contraction because you facilitate that actin-myosin interaction. Now, the antagonists have the opposite effect on this. So you could slow the contraction, and you have slow this arrhythmia. Now, these are beta adrenergic receptors. There's different types. There's beta 1 and beta 2. Beta 1 is the one that's the main one in the heart. There are beta 2 ones in other tissues, and that can have the selectivity between these can affect how specific your drugs are. Okay, so that's the target. What do these drugs look like? These have names I always kind of stumble over. Propanolol, the all-alls get me. Acebutolol, and some of these other, esmolol. But you can see, if you look at the structures, which is easier for me than the names, you can see a lot of things are very similar. You've got this ring here, this linker, and then this amine, which presumably it's secondary amines, so that's going to be in equilibrium, of course, with the protonated form. And you can see this is sort of conserved in all these structures. That's part of the pharmacophore. So these are all the antagonists. But we'll look at agonists in another lecture on inotropics. And you can see a lot of these things are conserved in agonists. Does that kind of make sense? Because if they're binding to the same site on the receptor, they probably have a lot of the same groups. So what makes one an agonist and another one called an antagonist? Well, if you look at some of these, and I'm not going to talk about the downstream effects of the agonists, but say you look at like this one. Really similar. You know, this amine out here, the substituent, the ring. But all of the agonists have this catechol function. These two alcohol groups off the phenyl ring, it's called a catechol. And that's sort of essential for these beta receptor agonists. And that's really how, just looking at the structure, you can distinguish, you know, even if you don't remember exactly where all the groups are, you know, if you compare one of these, like propanolol with isoproterenol, you can say, oh, this one's a catechol, that's going to be an agonist. This one doesn't have a catechol, that'll be an antagonist. So it's an easy way to sort of distinguish these structurally. Okay, back to the antagonists that lack that catechol function. The propanolol, it's non-selective, so antagonize both beta 1 and beta 2. But the rest of these are actually more beta 1 selective, beta 1 being the ones that predominate in the heart. So they're a little bit more selective drugs. Now, if you look at this structure, you do notice that there is a chiral center in here. There's 4 different substituents attached to that carbon. Now, propanolol, it's marketed as a racemic mixture. So one chiral center, you have both of them there. You administer the drug, both of these go into the system. But the S enantiomer is about 100-fold better than the R. And part of that is because the R gets metabolized and cleared faster than the S. It's recognized by these enzymes that cause the metabolism. So what happens in R is first you can get N-dealkylation, then you can get deamination, and then oxidation of this aldehyde up to the acid to give this naphthoxy acetic acid. And that's the major metabolite from this propanolol. Oh, we should probably do this. Okay, I'm going to be lazy. Let's put the one that has the proton in the back. That's going to be the least group. Which one of these is highest? We have an oxygen. We have 2 carbons. Oxygen outranks, so that's the highest. Carbon, both of these have 2 protons off of it, but one has an oxygen, the other one has a nitrogen. Oxygen outranks nitrogen, so 2, 3. That's in the back. You come around to the right, rectus, R. So that's your R enantiomer, and the mirror image is S. Make sense? Reaching back into RNS history there in your brain? All right. Now there's something kind of interesting about this class of drug that talks about a larger design concept in medchem. So I think it's kind of neat. It's called soft drugs. So the way this story came about is this metoprolol. You can see here the ring, this amine that can protonate. The metabolic pathway of this was discovered, and kind of similar as before, this gets metabolized down here to an inactive acid component. That's inactive. So this is a medicinal chemist. He's looking at this and thinking about this. Oh, I'm going to think about this. And he or she designs this compound called S-molol. And this is kind of interesting because she looked at this and said, okay, the acid is inactive. This neutral form is active. So what if I put something that can get broken easily, but broken in a very predictable way to get rapidly metabolized into something that is inactive? And esters are great for that because you've got a lot of serum esterases that can take the acid and rapidly catalyze that to break this down, hydrolyze that group. And once you make the acid form, you're inactive. And this results in a compound that's, works at the same place as the starting compound, but gets rapidly metabolized in this active one, and they call these ultra-short-acting beta blockers. So if you look at some of the others, the half-life might be 3 hours. This one's like less than half an hour. So super fast getting rid of them out of the system. So if you want a short-acting compound, they use this strategy called soft drug design to design something that gets metabolized in a predictable way so they can be rapidly deactivated or detoxified. So this is making something that's short-acting. But you can also imagine if you have a toxic drug, you don't want it to sit around for a long time. You might use soft drug design to make something less toxic. Does that make sense? These are actually kind of the opposite of prodrugs. If you think of prodrugs, these are compounds that are not active, but they get metabolized to make the pharmacologically active species. This is like the exact opposite. You give it a compound that's active, but it's designed specifically to get metabolized in a specific way into something inactive. Okay, I think that's cool. All right. Oh, yeah. So these are drugs of abuse. I guess I could use that lightly sometimes. There's a great article. It's a little old, but I don't know if there's anything that I've seen since then, actually. They call it pharmaceutically enhanced classical music. I like this. But I guess propanolol is used to control performance anxiety and stage fright. Some people say, oh, they don't play any better. Some people say, oh, yeah, they play better when they're on these. But when you use it for that anxiety, it's used at much lower doses than what's used as cardiac agents. And back, this study that they cite, it's back in the 80s. Even then, between, a quarter and a third of musicians in the largest orchestras have used these beta blockers, so probably higher for this purpose. And of those, 70% of them didn't get them as prescription. They just got them from friends. I love this quote. They're talking about someone on backstage, In some backstage area, they're passed around like chewing gum or mints. Someone said, recalled a panic colleague saying, "OMG, does anyone have any Inderal?" So, anyway, some people are like, "Oh, we should test the orchestras like at the Olympics to make sure they're not on drugs." But I think I'm more worried about safety concerns. If you're taking these at the at the increased concentration that you might for arrhythmias rather than for the stage fright, and if you're getting them from friends, it's not really a safe sort of usage of these. Anyway, it's kind of interesting. All right, third class. Amiodarone. Now this compound is kind of notorious, very high toxicity. Actually has multiple targets. It's the sodium, potassium, and calcium. That should be 2+. It should be up there. 2+. But also the alpha and beta adrenergic receptors. It affects a ton of different channels. Messy. And because of that, it tends to have a high toxicity. So it's often a drug of last choice. Now there are drugs that are less, but I'm using this as sort of an example of this category. Some people say it's structurally similar to thyroid hormones. That's just because it has iodine. I don't think it really matters that much in terms of the SAR. You'll see some examples that don't have that. This is kind of down in the weeds. I won't ask you to know about this, but it's kind of interesting that it has this this double bond, this single bond here, but it's actually, even though it's a single bond, you think it might rotate, even though you might have some resonance stabilization. It's actually held in one orientation. They call it an S-trans orientation. So here's S-cis, kind of like this would be a double bond that's on the same side or opposite. It's held there, and it gives the molecule a certain shape, which is an important part for the binding to the active site. Now this compound gets metabolized, kind of like we saw before. You can get N-dealkylation. You get des, missing, ethyl amiodarone, and still active, that metabolite. Some P450s, like CYP3A4, can dealkylate, and the way is kind of like we studied back in MedChem. You get oxidation of the adjacent carbon here, then the electrons come in and treat that nitrogen as a leaving group to break that CN bond and release your ethyl group as this oxidized aldehyde version of that, which then undergoes further oxidation in metabolism. Now, metabolism of amiodarone was actually kind of studied because it's thought maybe they could use a soft drug version of this to help ameliorate some of the toxicity. So, we talked about this S-cis bond. Actually, its function is to hold this butyl group in a certain position. Well, this is very hydrophobic. So again, here the med chemist, she was thinking, well, how do I turn this into an inactive metabolite? Same kind of ester trick here. You put an ester there, this will get rapidly metabolized, yield a negative charge there, it won't bind to the receptor anymore, it'll be inactive. This makes a very short-acting compound to avoid some of the toxicity. Now this is an in-the-pipeline drug. It's in clinical trials now. It's given a name, butyrodarone, but it has this ester here that's sort of that Stroff drug design to get rid of that hydrophobic group that's important for binding. There are others in this class, some in clinical trials, some approved, like dronedarone. A little bit more recent than amiodarone. But you can see it's lacking the iodines, so this I talked about how those weren't really essential for the structure. But you can see a lot of the same similarities. This butyl group that comes out that's disrupted by introducing that ester. All right. All right, so we're going to have a short day today. Summary, we talked about quinidine. We looked at its target, its binding site, the structure, those pKs of those two nitrogens, how it gets metabolized, and why it might have drug-drug interactions. We sort of parsed that out. We looked at the beta-adrenergic receptor antagonists, the structure, and the differences with the beta-agonists, how that catechol can really let you distinguish between the structures, which is going to act as an agonist and which is an antagonist. We did an example of the stereochemistry, and again, we looked at the target of these, the beta-1 distribution versus beta-2. And this introduced that soft drug concept, which I think is kind of a more global thing in medicinal chemistry and how you design safer medicines. Amiodarone, some of its many targets and metabolism, and how this soft drug concept may be successful in overcoming some of this toxicity. You've had digoxin and anticoagulants for treating some things in this class already, and I just put that pointer in because we'll be covering those classes in the inotropic lectures a little bit in the future. Okay, anything questions about this stuff? All right, you're going to have a rare early lecture then.
What should we focus on in the exam?
In the exam, I would go just over those points that I just talked through. I'm going to look at this slide here and say, what are the main points? I probably asked 4 questions out of this lecture, and there's 4 bullet points. I'm probably going to ask one from each one. Not exactly, but that's what I would do. Anything else? All right, thanks everyone. Hey, I'm going to stay up front for a few minutes in case you guys have any questions over previous lectures for getting ready for the exam.
to write down the final schedule, but I only have this crappy. So I only have this crappy. Where's the newsletter? One of my newsletters. I have a very tiny problem. But I mean, it's like very tiny.
That's actually just something like.
I know, I stepped outside in a sweater. But I wish that like I know, and we have all these exams in this quarter, so it's kind of hard. We have a weekly exam here, so actually I was really love it for you. I didn't even know. Definitely. Yeah, I can't do PT renal work. It's usually fun.
Oh. That was my favorite one.
In the middle of the beach? Next Wednesday? I have Armstead quiz like Are you gonna skip class?
That's just like.
You have lab? You don't have any lab. I have rugby.
Oh yeah, I have
We should do something
What's that?
I have the handphone.
I wish we could just get that experience and not be there, you know what I'm saying? Is that the final budget?
Yeah.
cups are $5. You get coffee free the first time you buy it. So it's really like $3. You're gonna buy one each, and then coffee's only $1 each time. And they used to give us free coffee on Fridays.
I guess they're taking advantage. Everybody's taking advantage of it. Like what? Stop it.
I think it was just a
A bit of a difference because you see like Malibu, you go along the processing thing.
Bro, I'm gonna start studying
I was still sleeping when I came in.
How even? How? I need some pill.
What time are they?
Yeah,
Yeah, we're not sleeping. I'm not okay.
No, what happens is I show up there after a week and something is changed for me, tells me, and then I do something. And then the technician's too dumb shit. I'm one of you. Why do you do this? Why do you make me connect with you?
It's just right. I'm doing like that.
In the cupboard? No. You need to talk to these men. Oh no. I will talk to this. Listen. No. Just two crumbs. Chilling. Get in the shower so that when you're done, They didn't say that. Because I wasn't sure what.
Life is not like it's infinite. Again, you don't get a script.
I will make my own story. I don't know how to you do, but like I just want to have a general idea of like if not
I was just still like, it was great. It's got the yellow. I can hear the rain and the roommates.
I like to do wake up. They're good. I don't have to finish it, but it's easy. Eat your way closer.
That is the right solution.
It's just the setup. Yeah. It's like this is fine. Sunday.
Garbage. None of the absurd. You have a nightstand? That'll burn for a while.
No, that's always when I want to like make stuff. I didn't work Friday.
That was awesome.
Literally every year it's undergrad. My first class day is really great. Am I ignoring this? That's what my grandma calls me. Like, but it's like that little like, it's weird. No one knows. When you hear that across the house, you're like, think it's pizza was like $7. And I would eat one. Definitely cheaper.
Just kind of follow through.
Literally, as soon as I change the station, it's like I finish that sentence and I'm done no matter what way it is. You can just use the same sentence 4 times with phrases differently. That's what I do. You do that with all of your sentences. It works.
Well, it's been on my tab. Some
Austin, this is Dr. Lam from San Antonio. Can you hear me? Right now, we're trying to get connected. First of all, can you hear me? And second, can you see the slide?
We can hear you. We can't see the
No,
slide.
we cannot see the slides.
Okay, all right. I think we have the IT person right next to me, so we're trying to see why it is that you cannot see the slide at this point in time.
God, I hope so. Give it to us, we can look at it.
Dr. Lamb, we can see a screen now. We can see that, but there's like a display window in front of it. That's good.
Okay, I think we're in business. Can you hear me okay and see the slide okay?
Yes.
All right, wonderful. Okay, my name is Francis Lam. I am with the Department of Pharmacology and Medicine at the UT Health down here in San Antonio. Also have a cross appointment with the College of Pharmacy. And I may be the only faculty who, because of my responsibility at the Health Science Center, really could not make it up to Austin to give you the lecture in person or so. So as I go through the lecture material, if you have a question and I probably cannot see you really well on the monitor, just use the microphone, raise your voice. I won't get upset, and just ask the question. Please stop me at any time if you want me to go over the material again. And we have about 3 hours or maybe 2 hours, 50 minutes, so we should be okay for today as well as tomorrow on Monday also. So I have some objective for this 3-hour presentation with you. The first one is I want you to understand what are some of the criteria for using drugs to treat ventricular arrhythmia. And over the last couple of decades or so, we have significantly changed our pharmacological approach to management of PVC or premature ventricular complex, as well as ventricular tachycardia. So we'll go through that. But before that, I would like to outline some of the pharmacological treatment approaches for patients who have different types of arrhythmia with most of the time spending on atrial fibrillation and to a lesser extent atrial flutter, because atrial fibrillation is the most common type of arrhythmia that you're going to see in the majority of your patient, either in the hospital or more likely in the outpatient environment also. Other than atrial fibrillation and flutter, some of the other different types of arrhythmia that we will briefly touch on include the reentrant supraventricular tachyarrhythmia, which primarily occur in the atrioventricular node itself, premature ventricular complex, ventricular tachycardia, and ventricular fibrillation kind of all lumped together, especially when we talk about the general treatment approaches, and again, what are some of the criteria that would dictate the use of a pharmacological management. So this particular slide looks complicated, but it is not. All I want you to kind of look at that is that there are two y-axes. One is indicated on the left-hand side, the United States population, and on the right-hand side, the atrial fibrillation population. And down on the x-axis is the age of the patient group. So essentially, what it is telling you is that atrial fibrillation is really primarily a disease much more common in the elderly patient population. So you can see that as the patient get older, somewhere between maybe 65 to about 85 years old or so, you can see that the incidence of atrial fibrillation significantly increased compared to the other age group, younger patient population, or maybe even the older, much older group, such as older than 90 years or so. So again, kind of similar to what is indicated at the bottom part of this slide, atrial fibrillation is really, really common, probably the most common type of arrhythmia, especially in men, especially in elderly. And again, if you, after graduation, work in the VA patient population, that will be one of the most common type of medical condition that you're going to likely to encounter. So if you actually remember, probably you have some pathophysiology in terms of understanding the atrial fibrillation, is that within the atrium, theoretically, you should be having just the sinoatrial node as the primary pacemaker. But in patients who have atrial fibrillation, in addition to the sinoatrial node, they are what we call multiple atopic foci. So if you take a look at the upper right-hand corner, essentially all those little circles with the little star just kind of give a cartoon representation of there are really multiple foci, and each one of them really screaming to be the one that I'm the pacemaker, and I should be the one who is dictating what the atrial rate and subsequently what the ventricular rate will be. So you can imagine that if there are multiple atopic foci, each wanting to be the boss and in terms of dictating what's to be the rate that the heart is beating, then you got multiple totally chaotic, disorganized atrial depolarization. Now, luckily, even though in patients who have atrial fibrillation, their atrium can be beating somewhere between 250 to 350 beats per minute, very seldom, obviously, that all of these kind of electrical impulses pass from the atrium to the ventricle. And that is because we do have that atrioventricular node, and part of the physiological function of the atrioventricular node is to kind of slow down and allow a part of the atrial depolarization to go through into the ventricle to depolarize the ventricle. So to a certain extent, you're not going to see the ventricle beating at 250 to 350 beats per minute or so. So again, similar to the second bullet point, only a small fraction are transmitted through the atrioventricular node. And essentially to stimulate that depolarization of the ventricle, which is indicated as the QRS complex on the surface EKG. So even that, though we only allow a certain portion of the atrial depolarization to go through, you're still looking at a ventricular rate somewhere between 120 to 180 beats per minute. So again, the majority of our patients would be symptomatic with palpitation, shortness of breath, dizziness. So that is something that we need to keep in mind when we come to think about the general treatment approaches to patients with atrial fibrillation also. Before we actually go on to talk about the pharmacological management of patients who have atrial fibrillation, and for that matter, patients who have any types of arrhythmia, and it doesn't really matter whether it is atrial arrhythmia or ventricular arrhythmia, is that if there are some underlying etiology or precipitating factor that could kind of put a patient into throwing them into atrial fibrillation or ventricular tachycardia, then it is extremely important to try to manage those underlying etiology or precipitating factor as much as possible, because otherwise we'll be kind of like chasing our tail just to give and maximize the antiarrhythmic drug therapy, and the patient will never get better. So some of the precipitating factor for atrial fibrillation include either cardiogenic type of etiology or non-cardiogenic type of etiology. So anytime you have structural heart disease, including myocardial ischemia, myocardial infarction, hypertension, cardiomyopathy, those are things that need to be managed. And likewise, if we have patients who have acute pulmonary embolus, chronic obstructive pulmonary disease, which is very common in the VA patient population, as well as any type of electrolyte imbalances. Those can be easily and should be taken care of, especially the electrolyte. They can be relatively easy to be managed. And by managing those precipitating factors, we may be able to put the patient back into normal sinus rhythm without the use of any type of single drug therapy also. When a patient has high adrenergic tone, which means that their sympathetic discharge is high, then obviously it's going to put the patient at risk of developing atrial fibrillation. So some of the examples of high adrenergic tone include thyrotoxicosis, alcohol withdrawal, sepsis, or a much significant increase in physical exertion that is not matched by the patient's cardiac output. And then I think you probably have already got a significant amount of lecture material on antiarrhythmic drug. And one of the things that you should know is that most of the antiarrhythmic drug, in addition to some other drug, can prolong the QT interval. So drugs that can, and as a result of them blocking the ionic current, especially the one that is the IK current also. So QT prolongation drug or QT prolonging drug are also something that, again, if there is no reason for those patients to be on those drugs that can cause QT prolongation, that should be evaluated as to whether it is necessary to maintain them on those therapy also. And then finally, even though we haven't been really using digitalis for several years now, because it is not really that effective for congestive heart failure, we have many other drug therapy that we can use. We still use digitalis for atrial fibrillation, and it's only in a limited way. But digitalis toxicity can cause any type of arrhythmia, and again, atrial fibrillation is one of them. So the essence of this slide is that I want you to remember is that you do need to take care of the precipitating factor, regardless of whether it is medical or pharmacological causes, and those need to be taken care of before we can optimally manage a patient with atrial fibrillation also. And if your atrium are not beating correctly because it have chaotic atrial depolarization, then one of the hemodynamic consequences of patients who have atrial fibrillation is that eventually you're not going to be able to fill the ventricle adequately, and you're going to have a significant reduction in cardiac output. Patient is going to be hypotensive. Another major complication of patient with atrial fibrillation is that the environment is kind of like an ideal for the patient to form thrombi within the atrium as well as the ventricle. And those thrombi are not really permanently attached to the myocardial wall. They are loosely attached to the myocardial wall. And anytime that we attempt to put the patient acutely back into normal sinus rhythm, then we run the risk of those thrombi going into the systemic circulation. And when they are in the systemic circulation, they can go to anywhere, but they have a very high tendency to end up in the mid-cerebral artery. The majority of them like to end up in the mid-cerebral artery, and that's when we actually would have a patient who can develop stroke because of those emboli blocking the mid-cerebral artery also. For a patient who has stroke, not only is it completely devastating to the patient, but it obviously also causes significant healthcare costs. And that is why, from a overall pharmacological management standpoint, and we'll go through that in the next couple of slides or so, if we have the opportunity to put the patient on anticoagulant, and it doesn't really matter at this point in time which anticoagulant we're going to choose. It could be the old established agents such as warfarin or some of the newer oral anticoagulant. But the reality is that if a patient, especially those patients, has risk factors such as elderly, prior embolic event, hypertension, diabetes, left ventricular dysfunction, then we need to anticoagulate the patient in order to reduce the risk of developing stroke. Now, the very last bullet point in here is that the risk of developing stroke is reduced in patients who have what we call long atrial fibrillation. And long atrial fibrillation essentially just means that we really couldn't identify any etiological factor or precipitating factor. Patients who have atrial flutter, especially those who have no underlying precipitating factor, again, basically they have a much lower incidence of thromboembolic event, and that would be something to take into consideration as to whether how aggressive we want to manage those patients with antithrombotic agents also. So overall, what are the pharmacological treatment approaches to patients who have atrial fibrillation? The first and foremost is to assess the patient's hemodynamic response to the occurrence of atrial fibrillation. If the patient is symptomatic from the standpoint, let's just say blood pressure is dropping, cardiac output is dropping, then you don't really have any choice but to immediately try to revert the patient back into normal sinus rhythm. And the way that we do it is basically do what we call direct current cardioversion, and we'll talk about that in the next slide also. So again, the first thing is to assess the hemodynamic response for those patients who have atrial fibrillation. If the patient is asymptomatic, or at least from a symptomatology standpoint, it's not really that critical, then the next therapeutic approach in terms of goal of the treatment approach would be to control the ventricular response rate, because we really don't want the patient to run a ventricular rate somewhere between 120 to 180 beats per minute also. So remember, we talk about that even though the atrium is beating at about 250 to 350 beats per minute, luckily we have the atrioventricular node that will slow down the number of electrical impulses that pass from the atrium to the ventricle. So essentially, what we want to do from pharmacological standpoint is to kind of help the atrioventricular node in that regard by giving drug that can basically produce an additional blockade at the atrioventricular node. So essentially, this group of drugs are what we call atrioventricular nodal blocker. And there are three primary groups of this so-called AV nodal blocker. One is the calcium channel blocker, the other one is the beta blocker, and then the last one is digitalis. And again, every single time you initiate drug therapy in a patient, you should basically ask yourself, what is my treatment goal? So the treatment goal, overall treatment goal is somewhere between 80 to 100 beats per minute. But again, I mean, that's where, as a pharmacist, you have a major role in terms of individualizing the drug therapy, is that the treatment response or the goal of the treatment of drug therapy in terms of controlling the ventricular rate has to be individualized to that particular patient. So sometimes, even though the majority of them, you may be looking at 80 to 100 beats per minute, sometimes you may be going down to 60 to 80, sometimes a higher rate of up to about 115 beats per minute may be necessary also. So again, the overall is to try to control the ventricular response rate. What would be the range of desirable response would be depending on the individual patient, especially taking into consideration of other concurrent medical condition and other concurrent medical therapy also. Then, if we have time, then we should actually also think about anti-thrombotic agent as well. So again, prophylaxis against thromboembolic event. And then after the patient's symptomatology is controlled, after the ventricular response rate is slowed down to an appropriate level for that particular patient, then the next question that we need to ask is, do we need to basically rework the patient back into normal sinus rhythm? And again, it's not just rework them back into normal sinus rhythm, but to maintain them in normal sinus rhythm. And reverting a patient and maintaining a patient in normal sinus rhythm may not be necessarily appropriate for patients who have chronic atrial fibrillation, and we have some data to kind of show you down the road or so. So again, most of the time what we need to do is kind of think of it from the standpoint of symptomatology. Is the patient symptomatic even when the rate is controlled? And more importantly, what is the likelihood of us able to maintain that patient in normal sinus rhythm? Because if the likelihood of maintaining normal sinus rhythm is low, then even though we revert the patient back into normal sinus rhythm, they're going to quickly revert back into atrial fibrillation also. So again, this particular slide kind of gives you the general approaches before we start talking specific about different drugs also. Again, assess the hemodynamic, controlling the ventricular response rate, prophylactic agent against thromboembolic event, and then think about whether we should revert a patient and maintain a patient back in normal sinus rhythm. So, if a patient is hemodynamically unstable, then again, as I said, what we need to do is basically directly apply direct current external cardioversion, and you probably have seen different picture of it in medical drama on TV, that someone is holding two electrical pad, and then you may kind of just slam it onto the patient. And what it does is that it's basically applying some sort of electrical energy to the patient in order to kind of shock the patient back into normal sinus rhythm also. And they are extremely effective. It is highly successful for reverting them back into normal sinus rhythm. You're talking about anywhere between 75 to 90% in response rate. And the downside is not really that much. Obviously, one of the first one is that if someone is applying that much of an electrical energy to the chest, minor skin burn is not unexpected. Other side effects include pulmonary edema, as well as emboli. And again, if the thrombi is poorly attaching to the myocardial wall, whenever we suddenly change and acutely change that rhythm by changing the patient's atrial fibrillation back into normal sinus rhythm, that's when those loosely attached thrombi are easily thrown into the systemic circulation. And when they're in the systemic circulation, they are known as emboli. And again, those emboli can end up in the cerebral circulation, causing stroke also. So again, you can see that there is systemic embolization. Primary concern would be stroke, and the secondary concern will be ending up in the lung, causing pulmonary embolism. And that is why we need to, if we can, as much as possible, to anticoagulate a patient. Anytime again that we cardiovert a patient with direct current cardioversion, the patient runs the risk of having different types of what we call post-cardioversion arrhythmia, and that make it important that as much as possible we would like to do the cardioversion in a environment that we will have defibrillator, and we will have some means of rapidly giving the drug or antiarrhythmic drug to the patient in order to control those post-cardioversion arrhythmia also. We also, if we can, especially if we can actually wait to initiate the direct current cardioversion, is to give the patient sedative And there are two reasons that we would like to give patients a sedative. Number one is to decrease the anxiety level of a patient. So, I mean, if you can imagine, if you are the patient and you see this physician holding up two big electrical pad coming to you and yelling at the same time, everybody clear, then it's going to be somewhat anxious to the patient, which already is kind of anxious because they have atrial fibrillation. And anytime you increase that anxiety level, you're going to jack up that sympathetic nervous system activation, and that obviously would not be good in a patient who have already high ventricular response rate also. And another reason, even though it is not as big of a reason compared to decreasing the anxiety level, is to use the sedative to provide some sort of amnesia so that the patient would not kind of remember that kind of event of someone slamming the electrical pad, putting a certain amount of electrical energy into the patient also. So if we have the opportunity in terms of the time, meaning that the patient hemodynamic response is okay, and we can wait in terms of doing the cardioversion, then some of the literature data, even though they're old, basically suggest to us that we can even increase that success rate with direct current cardioversion from 75% to 90% to almost 100% if we pre-treat the patient with drug. And in this case, published in New England Journal of Medicine in 1999, is that you can see that 72% success rate with direct current cardioversion, but if we actually pre-treat the patient with Ibudilide, which is a class 3 antiarrhythmic drug, the success rate immediately increased to about 100% or so. And that pharmacological pre-treatment also enables us to use a lower amount of energy applied to the patient. So again, if the patient is hemodynamically unstable, you shock the patient. And if the patient is stable and we want to revert the patient back into normal sinus rhythm, then think about in terms of you can pre-treat the patient with Ibudilide first and then shock the patient, and the success rate is almost 100%. So how do we control the atrial to the ventricular rate in patients who have high ventricular rate? And again, there are two different groups that are much more successful compared to digitalis. The first group is calcium channel blocker. And again, obviously, if you have a patient who have a ventricular response rate of 120 beats per minute or so, most of the time you do want to give the calcium channel blocker or the beta blocker intravenously. And the calcium channel blocker is very effective from the standpoint is that they actually produce what we call direct depressing effect on the atrioventricular node. So they can slow the atrioventricular node conduction pathway because that action potential within the atrioventricular node is highly depending on calcium. And that is why the calcium channel blocker is so effective. And by now, you probably know that there are two major groups of calcium channel blocker. One is what we call the non-dihydropyridine calcium channel blocker, with verapamil and diltiazem being prime example of those non-dihydropyridine calcium channel blocker. So you can see that you can basically give verapamil or diltiazem bolus over a brief period of time and titrate the additional doses if necessary to the response of the patient. So you give a bolus dose, and then if necessary, you get a second bolus dose, or maybe even give an infusion also in order to maintain and control the patient's response rate. For my section of the exam, I really do not want you to memorize any type of dosage information for any of the drug that we are going to discuss, because you will eventually get to kind of know what are the appropriate dosage regimen once you get onto clinical rotation also. I would rather you kind of be familiar with the overall pharmacological approach rather than spending time to memorize what is the dosage of each particular drug. Having said that, if other professors specifically require you to memorize the dosage of each individual drug, then it is a fair game for them to ask you in their part of the exam also. But for my part of the exam, you're not going to have to memorize the dosage of each of the different drugs. So under the sub-bullet point of diltiazem, you can actually see that I put down elderly and patient with low blood pressure. You decrease the dose or you increase the dosing interval. And it kind of makes sense because your calcium channel blocker in general are used as an antihypertensive agent. So if you have a patient who has low blood pressure, or if you have a patient who are elderly and their barrel reflex is not really that working because of aging process, then you need to kind of think about in terms of backing on the dose, or you increase the dosing interval. And the idea is to decrease that systemic exposure to the verapamil or diltiazem also. I talk about you can basically do infusion in order to control the response rate on a more permanent basis, at least short term. And eventually, if the patient are controlled on verapamil and diltiazem using intravenous brow administration, then you can put the patient, convert them back into the oral therapy, and then ideally, especially on an outpatient basis, you would like to utilize a sustained release product as much as possible also in order to increase the patient medication adherence. Again, the calcium channel blocker, because of the direct depressant effect on the atrioventricular node, are extremely effective in terms of controlling the ventricular response rate. Both verapamil and diltiazem have negative inotropic effect. So obviously, if you have a patient who have very low ejection fraction, that would be something that you need to keep in mind, and is to assess whether the patient would be a candidate for calcium channel blocker. So again, even though the calcium channel blocker are one of the first line agent for controlling the response rate, you have to kind of look at the individual patient and ask yourself whether that is the most appropriate agent in order to manage that particular patient also. In addition to the potential detrimental effect on the ventricular ejection fraction, some other example of contraindication include obviously severe hypertension, second or third degree atrioventricular block, because if you already have a patient who have second degree or even third degree atrioventricular block, then you are further enhancing those AV block, and you might actually put the patient at risk of complete heart block also. Cardiogenic shock, obviously, because of the negative inotropic effect of the calcium channel blocker. Concurrent intravenous beta blocker because of the additive hypotensive effect. So those are some of the examples that I want you to keep in mind, and more importantly, as to why that is the case. And then one final thing, the dihydropyridine calcium channel blocker are not desirable for trying to control the ventricular response rate in patients who have atrial fibrillation, because if you remember, the dihydropyridine calcium channel blocker are much more potent vasodilating agent from a peripheral vasodilatation standpoint. So one of the side effects of the dihydropyridine calcium channel blocker, such as nifedipine, nicardipine, etc., reflex tachycardia, and that obviously is not desirable in a patient who already have atrial fibrillation with high ventricular response rate also. In addition to the calcium channel blocker, and we also have the beta blocker. And again, we would like to use intravenous formulation of beta blocker. So any of those beta blocker that have a IV formulation available would be much more preferable to those that only have an oral formulation. And especially there is one beta blocker, which is Asmolol, is probably one of the very first line beta blockers that you should think about, is because it has a relatively short half-life, which means that it has a short onset of effect. Think of it in terms of, because of the short half-life, you have a rapid onset of effect because the drug can get into steady state relatively rapid. And it also, by the same token, having a short half-life means that it has a short offset of the pharmacological effect, so that now if you have a patient who all of a sudden becomes significantly hypertensive, then you can just turn off that Aspinall infusion and the blood pressure would be hopefully normalized in a relatively short period of time. So having a drug that have a short half-life both will be advantageous from the standpoint of rapid onset of effect as well as a rapid offset of effect in case of side effect happen that need to be taken care of. In addition to Aspinall, other drugs that have been utilizing quite often would be your IV formulation of propranolol, IV formulation of metoprolol, and again, those will be for acute condition. And once we stabilize the patient, and especially trying to discharge a patient, then you can put the patient on oral therapy. Again, keep in mind that using sustained release preparation as much as possible. One other agent that, especially for patients who have heart failure after myocardial infarction, will be carvedilol. And again, remembering from your pharmacological management of heart failure section that was given to you by other professor, is that we do have sulfur-beta blockers that have been approved by the FDA for management of heart failure. So carvedilol would be one drug that would be good if the patient, in addition to having atrial fibrillation, also have heart failure as well, because calcium channel blocker would not be appropriate for those type of patient population. So for the beta blocker, obviously, you think about in terms of what will be the side effect of beta blockade, then it will be hypertension. So again, anytime you put a patient on beta blocker, you should check the blood pressure, titrate the dose according to the blood pressure response, and again, address precipitating causes. If the patient becomes significantly hypertensive and beta blocker is still necessary, then one of the choice obviously would be Aspinall because of a short elimination half-life. Other drug that we can think about, especially if the patient has heart failure, is also hypertensive, then it would be Digitalis. And then finally, we always have that last drug of choice in a sense because amiodarone is very effective in terms of controlling atrial arrhythmia as well as ventricular arrhythmia, but just be aware that it is the most toxic drug that we have, at least as an antiarrhythmic drug and possibly for any other drug that we are aware of. So the next two slides that I have for you, I don't really want you to get so caught up in terms of all the different lines, and I basically put a circle for you to kind of like focus on those circles. And it kind of gives you an idea as to why Digitalis is not really that effective. And in this case, basically, we have a group of patients who have a resting ventricular rate of about 110 beats per minute or so. And you can see that giving the patient DITCH 0.25 milligram only result in approximately 12% reduction in the ventricular response rate. Doubling the dose of DITCH to about 0.5 milligram is really not that significant because it only reduced that ventricular response rate by about 18% or so. On the other hand, if you move to the right-hand side, again, no pharmacological treatment, placebo, essentially, you're looking at about 110, 111 beats per minute. But if we now combine DITCH 0.25 milligram with verapamil, which again have a direct depressing effect on the atrioventricular node, you can see that now the mean ventricular response rate is reduced by about 30% with the combination of DITCH and verapamil. And if we are actually looking at just verapamil monotherapy, you can actually see that the effect is about 21% reduction in the ventricular response rate, much more than the higher dose of digoxin by itself. The next slide essentially looking at the same group of patients, with the only difference is that rather than just looking at the resting heart rate, now the patient are put on 3 minutes of bicycle exercise. And then we measure their heart rate. And then again, with 3 minutes of bicycle exercise, as you can imagine, then the baseline heart rate could go up to about 160 beats per minute or so. And again, going through the same type of protocol, DITCH 0.25 milligram, now you're looking at a significant lower response rate of about 3% reduction in the heart rate. Doubling the dose reduced the heart rate by about 8%. And if you look at the other part, when you combine DITCH with the verapamil, now you're basically seeing is the same type of effective response, 29 to and 23% reduction in the ventricular response rate. So the two slides, essentially, what I want to do is to give you an idea using a study that kind of compared DITCH versus calcium channel blocker to kind of give you the idea that your digoxin is really not very effective in terms of controlling ventricular response rate, especially if there is a high adrenergic tone. Because unlike the calcium channel blocker, DITCH really only have a very minor direct effect on the AB node. The primary anti-arrhythmic effect of DITCH is really related to what we call the vagolytic action in order to increase the vagal tone, and essentially you're looking at parasympathetic system modulation also in terms of producing bradycardia. So it is not effective compared to verapamil or diltiazem, especially if the patient has high adrenergic tone. In addition, DITCH has a relatively long half-life on average in patients with normal kidney function of about 36 hours or so. So it's a very slow onset, and it just basically doesn't really revert the patient back into normal sinus rhythm. And even though we every single time we use digoxin, we have to kind of monitor the drug concentration from the standpoint of trying to prevent toxicity. There isn't really any type of good relationship between digoxin concentration and efficacy. So we can't really use the digoxin drug concentration monitoring to guide us for therapy also, other than to prevent toxicity. So pretty much the only time that we would use use digoxin in patient with atrial fibrillation is if we have a patient who have concurrent heart failure, which means that likely we are not able to use a calcium channel blocker because of the negative inotropic effect. But even that, you might want to kind of think about, can I use a beta blocker, especially those beta blockers that have been approved by the FDA for management of heart failure also. And then finally, if for whatever reason beta blocker doesn't work or are contraindicated, same thing for calcium channel blocker, and DITCH is inappropriate, then amiodarone, as I indicated in the last slide, is going to be our go-to guide because it is highly efficacious, doesn't really have a significant impact on contractility. But again, bear in mind that it has a significant incidence of toxicity, and its toxicity profile is widespread. I mean, like the drug can get to anywhere within the biological system also. So what I want to kind of go through is just one simple case to reiterate kind of the concept that I talk about. So if you have a 75 years old female with atrial fibrillation, heart rate 140, blood pressure 160/90, recently run out of an antiviral medication, which put her basically in terms of a high adrenergic tone, you can actually see that the patient, even after receiving 1.25 milligram of DITCH, basically really cannot control her response rate in terms of the heart rate. And the alternative drug, as far as route, would be your esmolol or metoprolol or even propranolol, because they are very effective in patients who have high adrenergic tone, because after all, they are beta blocker. If we have to think about a calcium channel blocker, the diltiazem have comparatively, compared to that of verapamil, have less inotropic effect and less peripheral vasodilating effect than that of verapamil. And whether we should convert a patient and maintain them in normal sinus rhythm would depend on, and again, several factors that we're going to talk about. But the most important thing is that I want you to remember is that you do need to treat the underlying disease because by taking care of that, the patient may spontaneously revert back into normal sinus rhythm also. So I want to quickly just kind
Dr.
of
Lamb,
yes,
I
ma'am.
have a quick question about that sample case.
Go ahead.
I don't think that we've ever talked about methimazole on the test. If you gave us a drug like that, would you tell us this drug in withdrawal can cause like a higher adrenergic tone or
Sure.
just
So
okay?
yeah, so my kind of like philosophy is that if I basically ask you something in a test that or in an exam that I will give you sufficient information, in my opinion, obviously, that you should be able to kind of handle that question also based on your knowledge of what we talk about in the lecture. So if it is not a drug that you're familiar with, especially you haven't gone through endocrinology, then I will tell you what that is to kind of give you an idea, kind of clue you into hopefully getting the right answer also.
Thank you.
Uh-huh. So I want to kind of quickly to go to talk about dronedarone, and you have plenty of material on the anti-arrhythmic drug itself already, but and obviously you know that dronedarone is the next generation amiodarone in a sense. We have high hope for them. Unfortunately, even though they don't really have as much toxicity compared to amiodarone, they actually have a significant negative impact on myocardial contractility to the point that the FDA actually have a black box warning of contraindication in patients with congestive heart failure. Head-to-head comparison, they're also not as effective compared to that of amiodarone. And the next table, which is now shown in this slide, essentially I want to kind of draw you down to the very last row, which basically hospitalization as a result of heart failure in patients who receive dronedarone. You can actually see that there's a huge statistical significant differences between patients who receive placebo versus patients who receive dronedarone. So pretty much right now, I would say that if we think that we need to use a class 3 antiarrhythmic drug and we're thinking about amiodarone versus dronedarone, I would say as long as you have all the baseline tests done and essentially are careful in terms of starting a patient on amiodarone, I would take amiodarone rather than dronedarone because pretty much I don't think the drug works as well as amiodarone, and it certainly has been a great disappointment for us, even though originally it was hoping that it can actually replace amiodarone also. I think right now it's about 10 minutes to the hour, and rather than trying to go through the next couple of slides, which essentially talking about different risk factors for embolic stroke, I want to take this moment, stop here and ask you whether you have any question on the material that I've presented so far, and we can take up the rest of it next Monday because we do have approximately 2 hours or so. So any question on the material that I've covered so far, especially the approaches to treatment of patients with atrial fibrillation? Okay, so if you don't have any question, have a good weekend, and I will see you next Monday.